Hello there, this is Dr. Brian Buchanan. This is a tutorial on trauma ultrasound and the eFAST examination. That's extended focus assessment with sonography and trauma. In this tutorial, we will talk about indications and limitations and risks of performing the eFAST examination. Arguably, the biggest benefit is early and non-invasive detection of fluid in a multitude of spaces, from peritoneal and pleural to pericardial, and also detection of things like pneumothoraces. This exam offers the greatest advantage in patients with hemodynamic instability who may require immediate intervention for a life-threatening condition, or who are unable to be moved to the scanner, for example, because of their condition. First of all, it's best to have a focused clinical question in the setting of trauma to best utilize information gleaned from ultrasound. Considering things like mechanism of injury, duration of transport, patient position, are all factors that may impact whether or not the eFAST examination will yield clinically significant findings. Prior to initiation of the eFAST examination, there are several important considerations on the patient's clinical status. First off, are they stable or unstable? Obviously, the patient who is unstable may require immediate intervention even prior to the eFAST examination, or if a finding is positive on the eFAST examination, may require intervention at that time. The patient who is stable introduces an additional confounder, as the patient may require a CT examination regardless of your eFAST examination. Is it blunt versus penetrating? The greatest amount of evidence is in blunt thoracoabdominal trauma in terms of picking up significant injuries. In a penetrating trauma, a finding may be clinically significant with high specificity, but it may not have enough discerning power to rule out significant intrathoracic or abdominal injuries. In the pretest risk of thoracoabdominal injury, if your pretest risk is high, then regardless of your eFAST findings, you may require either immediate intervention or further imaging, including CT. Contraindications. Well, there's no strict ones, obviously, but the key here is not delaying immediate operative management, such as hemorrhage from an open wound. Immediate surgical intervention is mandated. And it does not replace the need for formal imaging studies, but often this is based on degree of suspicion or pretest probability. It may be more difficult to detect things like rib fractures on ultrasound or flail chests. And this is the obvious advantage of performing a CT scan, which can investigate for collateral injuries. In the patient who is unstable with a positive study, obviously that may mandate immediate surgical intervention or procedural intervention. More difficult is a patient who has a positive study with stable hemodynamics. This obviously requires a much greater degree of discussion and debate, given the degree of suspicion and the need for further imaging studies. Ultrasound can identify the full extent of intraperitoneal injuries, such as visceral laceration and other collateral injuries. If a patient has a negative study and they are unstable, further imaging is likely required and may warrant a repeat eFAST examination with some position change of the patient. The terminology is precise. For example, it's often best to specify, first of all, what you see, such as lung sliding in this case, which we'll discuss in a later tutorial. And this suggests that there is likely no pneumothorax, which is the condition. This helps to separate your interpretation of the image from your application to the patient's condition. To declare a negative eFAST examination, the study must be done to completion with adequate quality acquisition. An incomplete study is declared inconclusive. One of the greatest risks is indeed overfixation in ultrasound findings at the expense of the patient's clinical status. The patient's clinical status is ultimately the bottom line of patient's management and further interventions, and this needs to be considered when using this technology. There are ways to overcome this overfixation. Obviously, items such as delegating performance of the eFAST examination to a member of the trauma team and not having the trauma team leader performing the examination, but also to delegate explicit roles in the trauma bay as is normally done. Specific concerns with the eFAST examination include things like user dependence. The user will require a high degree of training experience to evaluate and apply such scans. Evolving scenarios may indeed require multiple scans in the event that a CT scanner is inaccessible or unavailable. False positives, teaching and oversight, and one of the most egregious items is slow performance of the examination, which can really delay care and timely interventions. Concerns are broken down into roughly 3 sections: technological risks, interpretation risks, and patient factors. We will focus on interpretation risks and patient factors in the following discussion. False negatives are important to be aware of, as the patient can have significant internal and visceral injury without significant intra-abdominal free fluid. This can happen with many conditions, including pelvic injury and retroperitoneal bleeding. Furthermore, ultrasound generally plays a more limited role in the evaluation of patients with significant pelvic fractures because it is less sensitive for detecting pelvic bleeding and cannot differentiate between blood and urine. Again, it is important to consider the patient position, as a patient who is supine has two dependent portions of the abdomen and pelvis. That includes the right upper quadrant and left upper quadrant, and caudal to the sacral promontory, the pelvis. Again, false positives like physiological free fluid in a female reproductive age and pre-existing in cirrhotics, which need to be considered as potential confounders. It is important to know that trace free fluid can be particularly concerning if not overtly positive. This can really confuse management, as it could certainly be an innocent bystander. From our local anecdotal experience, trace free fluid is approximately 50% detection rate for significant pathology. Again, it's the risk of finding things that have always been there, whether it's the chronic pleural effusion in the cirrhotic or the ascites in the patient with peritoneal dialysis. This is an example of a false positive. The white arrow points to an area of perinephric fat. You can see there this is a mostly mixed hyperechoic and hyperechoic densities. This is far different from our anechoic, which is black on ultrasound. This is a potential false positive. In the following ultrasound, this is performed in the right midcostal region. In this area, in fact, we have a combination of intra-abdominal free fluid and pleural free fluid, with a diaphragm in the intervening space. This finding can be confusing to the novice sonographer, as there is indeed free fluid below the diaphragm and above the diaphragm. Patients can have a significant visceral organ injury without intra-abdominal free fluid, which can happen with items like significant pancreatic lesions, bowel perforations, and visceral lacerations. Patients who are very early post-injury may not have significant free fluid developing in their abdomen. Also, further to this, really we can't comment on visceral organ injury without expert guidance or CT imaging, such as the degree of liver laceration. Another factor in ultrasound is the image acquisition. This is a change of blood echogenicity over time. On screen right, we see here that fresh blood is anechoic. That means lacking internal echoes. In the middle, we see hypoechoic. This is perhaps newly clotting blood, which may be of mixed densities. In the image below, we see isoechoic. This is commonly not seen, as this is really old clotted blood or tissue that's been there for a while. Gas in ultrasound can also be noted. Bowel gas can be quite irritating while trying to assess abdominal viscera and may require some firm compression to occasionally minimize this interruption. Furthermore, patient repositioning can also work if the patient is able to tolerate. Subcutaneous emphysema from open wounds or pneumothorax can prevent adequate ultrasound of underlying organs. That's because air causes intense scatter of the ultrasound beam, and therefore the ultrasound beam can't penetrate to structures beneath. And air itself manifests in multiple ways in pathology such as fournier's gangrene, pneumoperitoneum, and pneumothorax. You may need to reassess frequently, as bleeding may be absent one moment, present the next, much like your ABCs if your status change. But again, this should not delay other studies or interventions. A brief discussion about training and exposure. As with any technology, education, training, and ongoing support is required to become proficient in this examination. This must be balanced against the patient's needs for safe and effective delivery of care, to minimize interruptions and minimize confusion. Obviously, in any instance where a patient requires an immediate eFAST assessment with high accuracy and speed, it may be judicious to choose the person with the most experience and training in this examination. So take-home messages. Be clear on indications for eFAST examination and in which instance you're using it, such as pre-test, mechanism of injury, hemodynamic instability. Avoid sonar distraction. And in many cases, CT is needed regardless of study findings to investigate for collateral injuries or if a significant mechanism is present. We discussed these three separate risks. I want to thank to Dr. Fung, Williamson, Witter, Peyton, Gay, and Mador for providing their local experience with pitfalls in the performance of the eFAST examination. Thanks.